democratic elected governors, which you can, if you want to, join our member service and if you join our membership, that enables you to have the opportunity when we have vacancies to join us as part of a governor group within the organisation. Without further ado, I'm going to hand over to Dr. Olivia Stevenson, and she's going to talk to us about preventing and managing skin cancer. Thank you, Olivia.
Hi, hello everybody. So welcome. Thanks very much for the introduction. So sadly, because I get so many emails, I didn't really read the title very well. So I haven't actually focused my tech talk only on skin cancer. It's a bit of a general talk through skin issues that all of us might have, including some top tips on skin cancer. And certainly we can spend some time talking about that a little bit more if that's really what people are interested in. So we're going to go through a few things. I'm going to share the lecture on Teams. I'm going to stop for some questions if there are any as we go along. And somebody else is going to be looking out for queries with people who can't see the next slide or any issues. So Jane, you'll let me know if there are problems, won't you?
Absolutely.
Right, let me get the right presentation first.
If I could just let people know that we are recording this, but obviously questions at the end, it'll be switched off at the end before the questions in order that to protect people's privacy. Thank you.
So can someone tell me if we can see all that nicely?
Yes, we can.
Good. Hi, so I'm Olivia. I'm Olivia. Did you hear all that? I'm says I'm muted, but
yes, yeah, oh, yeah, no, you're quiet again.
Can you hear me now?
Yes, we can.
Yeah, okay, sorry. Okay, so I'm Olivia. I've been at Kettering Hospital as a consultant since 2005, so nearly 18 years now. I lead the department and I'm skin cancer lead. And increasingly, we are seeing that the public are very worried about their skin, and we have more and more referrals. And I think partly that's because we are more aware of concerns. And I'm just going to talk you through a few things that I wanted to discuss today and give you the opportunity to ask some questions, hopefully later. So we're going to talk about some common conditions. So we're going to talk to you about how you look after your skin and how you prevent and pick up skin cancers. I'm going to look at some common treatable skin diseases and give you some tips. I'm going to suggest some ways that you should access medical advice. I'm going to briefly talk about some cosmetic issues as well. So I think it is really important that people don't overwash. So this is one of my little pet peeves. Us Brits are very obsessive with our daily showering, and actually what happens is that the skin barrier, we have a phrase in England, don't we, called soft as a baby's bum. And there's a very good reason for it, because when you come out, unless you have some problem with you, when you are born, you have perfect skin. Perfect skin that is well hydrated and nice and bouncy and squeaky. And it's covered in a waxy waterproof layer. And that waxy waterproof layer protects us from the outside world. And it does a really good job of protecting us from infection, as well as making the skin bend easily, and it's supple. It doesn't bruise. As we get older, we've all noticed that the skin dehydrates and becomes drier and bruises more easily, tears more easily. But we can do things that are that help that. When we use soaps, now soaps contain saponifying agents. Any of you who remember any chemistry, saponifying agents are things that dissolve fat. And we all remember the Fairy Liquid advert where that lady would run up and down this long pile of plates that Fairy does your dishes, cleans twice as many plates as anyone else, because the fairy is dissolving the fat in your food on your plates. Well, it also dissolves the fat on your hands, which is why we wouldn't dream of showering in fairy liquid. But our shower gels are not that different. They contain really strong detergents to degrease the skin. And so unless we are dirty, it is quite important not to use too much soap. I tend to tell most of my patients to use soap in your armpits and groins, but you don't need to be lathering up all over. And you should use products that are suitable for your skin type. If you are oily skinned, you should use oil-free moisturizers. And if you are dry skinned, you should be using a rich moisturizer every day. It's also really important to realize that if you spend an awful lot on your skin products, it's very unlikely that you'll be any better off than someone who gets those the Lidl own brand. So what things damage your skin? Well, too much sun and smoking are very big ones.
You were looking at.
Can someone mute? Too much sun and smoking are the big things that cause our skin. Too little sleep, dehydration, chemicals, and alcohol can also damage our skin. Fatty foods and chocolate probably don't damage your skin. So to look after your skin, we should be moisturizing. Now, it's quite hard to persuade my male patients to moisturize. They don't really like the idea of it, whereas most of my female patients probably have tended to moisturize at least after showering semi-regularly ever since adulthood. I don't know why there is such a cultural difference there. It's really important that you use a sun cream when we're out, and we will be talking a little bit more about sunscreen. Obviously, it's really important that we drink plenty. It keeps our skin well hydrated, but it's also very good for our kidneys. Most of us don't drink nearly enough. I think there's plenty of, most of us are quite aware of that as well. Try not to pick at things. Now, the reason I say that is that we you know, all of us tend to, if you've got a scab, you want to pick it. The trouble is that when we see some of our skin cancer patients, and they assume that something was going to heal, but they've been picking at it, and so they blame the picking on the not healing. So if we're not picking at it and something isn't healing, we know it's wrong. It's really important that we make sure we don't ignore when something's wrong. Now, although a significant proportion of my patients have been more vigilant since our pandemic, I have had a minority of patients who hid away during lockdown and didn't want to come out again. And we have had, sadly, quite a lot of patients who presented really very late with skin cancers that should have been treated a long time ago. So it's absolutely vital that if you are unhappy with something on your skin or any other part of your body, that you make sure that you seek help. And I know that that's really vital at this moment, because actually GPs are overrun at the moment. I know they get a lot of bad press, and I know that they work really, really hard. But there have been so many changes over the last 3 years that it's been impossible for us all to manage within the NHS. You're probably not aware, but NHS, the GP numbers are down 7% lower than they ever have been per patient. So we are significantly lacking in GP numbers. And patients are just, unfortunately, I don't know, look around the room if you're in one, patients are getting older. And with that comes a lot more illnesses. Conditions are a lot more treatable. So there's a lot more drugs and things to offer. So the GPs are just really overrun. And so it's really hard to see your GP. But luckily, there are other ways of getting in. So we'll talk about those later, because it's really important that we do get in when we need to be seen. So these are all the things you need when you are looking after your skin. You need a sun cream, you need a gentle shower gel, and you need a moisturizer, and that's about it. You know, you don't need much more. Any sun cream will do. And to look after your skin, and moisturizing and sun cream are the biggest things to keep you young. The sun, I don't know, let me have a quick check at my the sun is the biggest thing that causes skin cancer. So probably nearly 90% of skin cancer is caused by sun exposure. So it's really important that you're aware. I get a lot of patients tell me, but I don't sit in the sun. I don't know why we think we're going to dodge the sun's rays. They are not going to be avoided just by walking around. It is not necessary to stand still to get a skin cancer. So if you are an outdoorsy sort of person, if you enjoy walking the dog, being out on long walks, playing golf, playing tennis, just generally an outdoorsy sort of person, you are at risk of skin cancer. If you were born before 1980, you're significantly at risk of skin cancer because we didn't have any sun cream. We didn't know that sunburn was bad. So it's almost inevitable that you have burnt as a youngster. Your sun tolerance is directly related to your skin type. And skin type means really how easily you burn. And it's classified into 6 groups. And most of us Brits will be somewhere between 1 and 3, either extremely fair, typically redheads always burn, never tans. Now, in fact, most redheads under the age of 50 are slightly lower risk because it hurts to burn. And a lot of redheads will avoid burns like the plague and therefore don't get out an awful lot, don't spend that much time in the sun, and therefore, as a consequence, aren't as at risk as they might be compared to a skin type 2 who can tan. Because we all know, and we all either ourselves or have friends who, even though a tan is rare, they are desperate to cling to it and they will go through the burn to get that tan. Medium skin like me, I will burn if I'm not careful, but I can tan. And I'm probably even going towards olive skin as well. So darker skin people can get skin cancer, but in the majority of cases, they're not related to the sun. So here we have the 6 skin types here. You are much more likely to burn the lower number, and you are much more likely to develop a skin cancer. You need much more sun protection. You need higher factor cream, and you need high factor sun protection clothing. Now, some people think that almost all my patients are surprised about that a t-shirt doesn't give you that much protection. So this flimsy t-shirt that I'm wearing today, if I can see my hand through it on a sunny day, then it's not giving me a total block. It's probably giving me about a factor 15. Most of us should be aware by now, there's a lot of media about it, that anything less than factor 15, you are wasting your money. Don't bother. I'd probably take that for any skin type 1 and 2s up to a factor 30. You are wasting your money getting any sunscreen that is lower than factor 30. Your clothing needs to be thick if it's going to protect you from sun. And there are more and more sun protective clothing out there, which allows you to engage in, water sports and sailing or whatever else you want to do without looking like a wrapped up freak. You can have a lovely blouse or a nice thick shirt, which will still be cool, but will give you a total sun protection. We need to be vain, the sun is the biggest thing that ages us, and we've all got friends who love the sun and look like a bit of a handbag. It produces very dark wrinkles, deep wrinkles in the skin, produces blackhead-like changes, makes your skin baggy and saggy, and produces fine lines and wrinkles. It is the biggest thing that ages us, and it is definitely aggravated by smoking. So what happens when you smoke? The chemicals in the smoke activate the sun, the UV in the light, and actually, exaggerate your sun aging even more, which is why you might sometimes associate smoking with looking very old as well. So really important not to use your sun cream only when you're on holiday. We have plenty of sun in the UK. People often scoff, oh yeah, well, I don't need it in the UK, do I? Well, actually, we do. We definitely do. We'll all have noticed it in the last 3 years, but even before then, we have summers that can be anywhere through from May through to September with UV radiation that is well enough to cause skin cancer. I have plenty of patients who have never holidayed abroad who have skin cancer. It's important to think about your sun cream. So it gets rather complicated and you don't need to spend a lot of money, but you need to make sure that it covers you for UVA, for UVB, and for daylight. So UVA is the sunlight that's there in the summer that can gives you, you're more likely to have your sunburn. UVB is more likely to give us our skin cancer. Daylight gives us pigmentation changes. So when you choose your sunscreen, you should really be looking one that has all three. It says it will protect you for UVA, UVB, and if you are concerned about photo aging and looking old, you also need daylight. And if that is the case, the only way to protect yourself from daylight, look around the room, all of that stuff around you, that's daylight. You don't need to be outside for it even. It's bright light, and daylight is everywhere. It needs to be tinted. The only way you can stop daylight getting to your skin is to use a block. So you need a tinted sunscreen. And that's what's going to protect you from those unsightly pigmentation changes that you can find, especially that come up in the summer. Okay. So the big thing, obviously, sunburn hurts. It's really not very, very nice, but we know that sunburn under the age of 5, and I'm sorry if I repeat myself because I might have said this in a later slide, sunburn under the age of 5 is the biggest risk factor for skin cancer. But sunburn per se, on its own, that is a significant risk factor. If you ever allow yourself to sunburn, you are putting yourself at risk. Sunburn at any age almost doubles your risk of melanoma. Now, melanoma, when I first started giving talks 20 years ago, was a fairly rare cancer. It's now 4th and 5th commonest skin cancer in Britain in females and males. So this is really quite common now. After breast, bowel, and lung, I think it's skin. So you know it's common. As I said, sunburn under the age of 5 is a significant risk factor. Being fair-skinned, regular burns, and chronic exposure, and also family history to a degree. So this lady, you can see, actually this lady's Italian, so she doesn't have particularly fair skin, and she has a very dark area by the corner of her eye. The thing is, and this is the thing I think we all need to take home from this, is if you saw that and you had talked to this lady for 5 minutes in Sainsbury's, and you were then asked to describe her to a policeman because she shoplifted 12 bottles of Pinot, you would probably mention that she had a mark left next to her left eye because you noticed it. Anything that stands out from the crowd, you need to be aware of. This lady has olivey skin. She had lots of little freckles and little red marks, but this black thing right by her eye leaps out and pokes you in the face, and it should do. And if anything does that on you or friends, that's when you need to seek urgent help. If someone's coming up to you regularly and saying, what is that on your face or what is that on your back, you need to make sure someone's checked it out. So these are all examples of melanoma. And I'm a bit proud of the first one in the top right-hand corner. That it's a little bit blurry. We didn't have excellent photographs back in 2007. That photograph was taken because our mobile phone cameras weren't nearly as good as they are now. And I'm proud of that because that was the first melanoma we picked up on our first Skin Cancer Awareness Day that we had last week, our Skin Cancer Days. So I decided that it would be a good idea to open the doors on one Saturday to let anyone walk in. And I was rather slagged off at the time for touting for business. I got a quote from somebody, but certainly we managed to pick up some skin cancers. And this one was on the neck, and we picked up another one on an ear. So these are things that patients had not been previously worried about. And what we notice with all 3 of these moles here is that they don't look anything like the moles that you have on your body most of the time. Most of us have pinky brown moles or coffee coloured moles that are 2 colours or 1 colour even. They fade out towards the periphery, and if you chop them in half, left or right, top or bottom, horizontally, they look approximately similar, left to right, top to bottom. If you were going to treat them like a piece of cake and you were going to cut it up any way you fancied, most of the slices of cake would look just like all the other slices of cake. You can see with these that is not the case. Not all melanoma has to be irregular in shape. You can see that one in the top corner is nice and oval still. And not all moles, normal moles, have to be perfectly oval. Some moles are funny shapes, especially if you've, as a youngster may have scratched that area and picked a bit off even. But moles aren't always perfectly round and even, but they are symmetrical. So we don't like any of these moles. We don't particularly like most moles that are over 4 or 5 millimeters in size, so 0.5 centimeter, unless that's you. If you are covered in lots of big moles, then that's normal for you. But what we don't like is moles that have asymmetry, which means that top and bottom, they're not the same, left and right, they're not the same, or think of that cake slicing analogy. If you dished up that mole as a cake, every slice would look different from another. So this is another one, quite a subtle one, but that's a pinky thing. But you can see the top is pink, going towards the bottom, it's fading into brown, and then it's got 2 black specks in it. So we've automatically lost all of that symmetry I talked about. Top's pink, bottom's brown, 2 black spots. So that is melanoma, and melanoma is really the one we need to watch for, because melanoma kills. Melanoma is like breast cancer. We can cut it out and it still may come back years later. It is really important that we cut it out early to reduce that risk. Now, unfortunately, unlike melanoma, we haven't found a good way of screening for melanoma, except to do things like I did last week, where everyone walks in and strips off and I look at their moles. However, there is a blood test on the way. So I think it's going to be really, really interesting over the future. We're going to be able to start picking up melanoma in the blood. So these are 2 of the other common cancers that I see in clinic. Now, the one on the top left-hand corner is called a basal cell carcinoma. And these grow very slowly, and they tend to appear as something that just won't heal. So a little cut that scabs and weeps and bleeds and then heals over and is back again. And any of you in the audience who've had a BCC will probably recognize that story. In fact, my patients often come in and say, it's nearly gone now, doctor, I don't need to see you, but then it's back again. And we have plenty of time with BCCs because they do grow very slowly, but of course they do grow, and the bigger they get, the more of a challenge it will be to remove them, because that's what we're going to need to do. We're going to need to cut them off. And that's going to involve a little local anesthetic procedure, and 9 times out of 10 or even more, it's very straightforward. So even in this chap on the top left, it's going to be very easy because we've already got a filter and we've got a nice little crease under our nostril, and the scar will hide in there very nicely. So don't be worried about the surgery. My patients don't come because they're scared of what I'm going to do to them, and then they wait. And of course, the longer you wait, the worse the surgery is going to be. So anything you're worried about, just get it checked out. BCCs are pretty typical. I know I can say that because I've been looking at them for 25 years, but they do all the things that I've just said. They scab and weep and bleed, but don't heal. The one in the bottom corner, you'll notice, is lumpier and more flesh coloured. So basal cell carcinomas are often quite shiny, and you might, some of the discerning on you or ones with good image quality on your laptops may notice that it's got a bit of a shiny rim to it. This lump on the cheek here is just, I like to liken it to a rhubarber. Don't know how many of you remember rhubarbars, but it's like a donut with a crust on top. So this is a squamous cancer. Now, most of our squamous cancers present fairly easily because they are really not subtle. They grow very rapidly, something that starts out like a spot that won't heal, but within a couple of weeks is now a pimple, and then a couple of weeks later a lump, and then a boil, and then that. You don't go around ignoring that. If you've got a spot that turns into a boil within 4 weeks, you tend to go and see your doctor. And that is one of the cancers we see on the 2-week wait. So some of you may have been unfortunate enough to have had to have a 2-week wait appointment. And we see patients who the GP is concerned about melanoma and squamous cell carcinoma on that fast track pathway. We see you within 2 weeks. Basal cells we don't, because they grow much more slowly. So I'm probably repeating myself, but you're especially at risk of skin cancer if you have fair hair, fair skin, blue, green or hazel eyes, freckles, you tan poorly and burn easily. If you have large numbers of moles, especially if you have over 100 moles, you are at significantly increased risk of developing melanoma. And up to 1 in 10 melanomas occur in people with inherited predispositions. However, I think it's much more important to remember the biggest thing we inherit from our parents is our habits and our skin type. So if you are fair-skinned, it is likely you came from fair-skinned parents. And if you enjoy being outdoors all the time, it's likely that's how you were brought up. So if your family have always been outdoors, then you are going to behave in this often in the same way. So it's really important to protect yourself. You mustn't forget that a heavy tan is also DNA damage. I've told you about sunburns, but actually any tan, so a little bit of golden glow. We all love to feel the heat of us on the in the sun in the summer. We all like that slightly healthy golden glow. But if you are getting a deep tan, you are getting DNA damage, and that means that the sunlight is getting into your cells and causing changes in the cells to the DNA, which is the starter of the skin cancer. Many of my male patients present with melanomas on their back because when they were young and possibly still, they strip off in the garden and get on with their laying the patio or doing the garden, or people who work outdoors will take their shirt off and you can't see their back. It's always shocking to me how many married men whose wives haven't seen their back in many years. You must get your back checked. I tend to suggest that once a month, after your shower or bath, you stand butt naked in front of the mirror and just have a good look at yourself. Stand and look, and then turn around and look over your shoulder, try as much as you can to see the back of you, and turn the other way and see the other side. If you do that all the time, just like with your breast examinations, if you're ladies, you'll just start to notice, hang on a minute, I don't remember that there. You'll notice that something's changed. Spot those changes early and get advice, and then we can sort it out, because actually most of my patients are cured when we treat their skin cancer. So many of you will have heard that there's much stricter legislation around sunbed use now. It's illegal to have sunbeds under the age of 18. And that's because we know that all we're doing is storing up loads of sun damage for lots of skin cancers and photoaging in the future. There is absolutely no evidence that it protects you from holiday sun damage. However, I've put there ever in question marks. If you are the sort of person that has, 2 sunbeds before your niece's wedding, or 2 sunbeds, because you're going to, I don't know, somewhere incredibly hot for 2 weeks, and you know that you will burn if you haven't got a little bit of hardening. Having 1 or 2 sunbeds every couple of years is not going to do any real harm, but we know that 10 sunbeds a year for 10 years doubles your risk of cancer. I wanted to talk to you again about seborrheic keratoses. Some of you will have heard of these. They're rather unkindly used to be called senile, because they are probably the thing most people worry about needlessly. Almost all of us have some, and they do all the things you're told to look out for. They do all the things you're told to mention to your GP. So they itch, they bleed, they change in colour, they change in shape. So they're all the things you're told to keep an eye on, and they do them. So how are you supposed to tell the difference? They can hide a skin cancer, but they will never be a skin cancer. So we get a lot of patients turning up to mole days year after year to get their seborrheic warts checked again. The seborrheic warts are still seborrheic warts. They will always be seborrheic warts. And getting an idea of what your seborrheic warts look like is also really useful. So this is just a page I have just screenshotted off Google. You can see they all have some typical features. Although they all look very different, they have a warty, crusty surface and a stuck-on appearance. And most of you will have 1 or 2. Some of you will have many. They're particularly common on the back. Some ladies get them under their breasts. Some people get them around their neck when they can be very much more skin tag-like. As you can see, some people get hundreds on their back and hundreds on their face. And the only difficulty with this is, of course, that doesn't mean you don't get a skin cancer hiding in there. You're just less likely to notice it. So it is important, again, to keep an eye. But you can see how warty that surface is. It's like a cauliflower. And so bits of that get ripped off easily. And that's when they suddenly get very angry and inflamed and change very suddenly. They can get really puffy and swollen and itchy and sore. But they do it so quickly that we don't worry about skin cancer, because they do it more quickly than any skin cancer ever forms. So if you've got something that was okay yesterday and today is sore and tomorrow is angry and inflamed, and by Saturday is bleeding, then that's a seborrheic wart that's been caught rather than a skin cancer. So I'm going to take a pause there and answer some questions about skin cancer. If you don't want to be on the voice that thingy, then don't ask a question till the end, because this bit does get recorded. Does anyone have any questions, burning questions about skin cancer?
I've had some submitted by email, Olivia.
Shall we do those at the end then?
Yeah.
Okay. All right, well, we'll move on. But I did have one that I will talk about now, because I had a question sent to me: do all skin cancers need to be treated? Specifically, that was about basal cell carcinomas. Now, unfortunately, basal cell carcinomas come in all different shapes and sizes, and many patients have many basal cell carcinomas. And I have had patients who, over the years, they didn't believe me at first when I first told them they had a basal cell carcinoma and it needed to be treated, and they had this horrible C word, this cancer word. And I said, in time, this will be very normal for you, because unfortunately that patient had 8 or 9 the very first time I met her, and 20 years later, we still get another 3 or 4 every year. Clearly, for some patients, treating all the skin cancers isn't necessarily appropriate. Basal cell carcinomas should always be offered treatment, but actually, when we get BCCs, that's what we abbreviate them to, on the trunk or legs, they're often really flat, and all they appear as is a little red dry patch. And if they are small and not causing any bother in an older patient who has other medical problems, then probably there's not a lot to be gained from treating them. And do feel free, whoever's on the call, if they ask that question, to let me elaborate further if you need to later. Right, I don't know how late we are, probably very late, but at least we did the skin cancer stuff, which was what you were here for. I'll zip through some common skin diseases. So skin disease accounts for 20% of GP consultations. Most skin diseases are not curable, but treatable. I see a lot of teenagers with awful acne, and it really can affect quality of life. It's important that we don't tell our teenagers to just put up with it, it's going to grow out of it. We do need to treat, because it can be left with scarring, and there's no need. It isn't just a normal part of growing up that every teenager has to go through. There are some really good treatments available, and we should encourage our teenagers and young adults to get treatment early. Increasingly, we're seeing a lot of acne in adults, and treatments at this age are still excellent, and it's important. You don't need to put up with it. So I have patients who've had acne for 20 years, and they think they just have to live with it. That's not the case. What happens with acne is that this is what's called the pilosebaceous unit, and we have a hair follicle attached to a gland, and this is the pore at the top of the skin, which gets blocked, and that's what causes a blackhead. And it's the sebum that blocks this pore, and that can then get inflamed with bacteria, which causes a white or yellow pustule head. Infection is not the issue. It's only the bacteria part of the problem, but they are normal skin flora. So antibiotics work by clearing that bacteria, but actually most of them work by anti-inflammatory properties. It's the sebum that's the big problem. And you can see that both of these are quite oily. So you can see around this chap's nose and chin, it's oily. And this poor girl has lots and lots of blackheads all over her head and more spots on her face. So the self-help, cleanse daily. You should use a mild soap or a soap substitute if your skin gets a bit dry. Avoid abrasive cleansers. Use oil-free products. Don't pick the spots, which can cause scarring, but you can get comedone extractors, which can be helpful. There are over-the-counter drugs, lots of them. You don't need to spend an awful lot of money. Freedom is a name that often gets used. Nicotinamide and retinoids and benzoyl peroxide. These are all drugs that are very commonly used over the counter and can be very helpful. But you shouldn't expect miracles. Things take time. Nothing's going to work in a week or two, and a lot of them are quite drying. So patients stop their drugs because it dries the skin out. You just need to use it less frequently or with less contact time. We often use antibiotics to treat acne. But as I say, they're used for anti-inflammatory purposes, and they do need to be taken for 3 or 4 months. Unfortunately, there's an increasing amount of evidence that even a few weeks of antibiotics at any stage significantly disorders our gut microbiome. So I don't know how many of you have heard of the microbiome. This is the bacteria that live in your gut that makes it do all the things it's supposed to do. And when we have even just a single course of antibiotics, it can take a couple of years for your gut to recover. So understandably, patients are often not particularly keen on antibiotics. We use the oral contraceptive pill and hormone blockers in ladies with acne because we know that the androgens in the skin can really aggravate the acne. This is not because you have abnormal hormone levels. Even in polycystic ovary syndrome, it's very rare that your androgen levels are higher. It's just that the skin is more sensitive to them. We then also use a drug called isotretinoin, and there's a lot of press about that particular drug, but it's much better used early. If you have severe acne or you have friends or family with severe acne, don't delay, get them to come and speak to somebody. There's a lot of worry about antibiotic resistance. So apart from affecting your gut microbiome, we are worried globally about lack of antibiotics. So for some patients, antibiotics work really well, and they work really well for them, and that is fine. If there is no particular reason that an individual person should feel that they can't have antibiotics if they are the one thing that really helps. Some of my rosacea patients particularly find that antibiotics are the only thing that keep them clear. They are not likely to do you any significant harm once you have got through that initial stage where it affects your gut. It is more the fact that worldwide we know that we need to reduce our use of antibiotics. Dermatologists are the biggest prescribers of antibiotics for a non-infection. So we use antibiotics for their anti-inflammatory purposes for a lot of conditions. And so we are unfortunately wasting their antibiotic properties. So in some respects, it would be safer to be on the pill or to have isotretinoin or to talk about other medications. Scarring can be permanent, and although there are treatment options, they never clear the scarring completely, and they're only available privately, and you should only seek a laser opinion or a specialist a cosmetic opinion once you no longer have any active acne. I'm going to talk a little bit about chronic skin disease because we see so much of it, mainly eczema and psoriasis. They're very, very common, and neither are completely curable unless you have an allergic eczema. But most of my patients can be managed very well with a variety of treatments. However, treatment is long-term. Eczema comes in all shapes and sizes, and so sometimes it's difficult. Patients say, well, this new rash doesn't look like my old eczema, or it doesn't look like my brother's eczema. It can look different, and often looks different at different stages in life. So very young babies tend to have eczema on their cheeks, and they rub with their hands on the cheeks, and that can cause this weeping up here on the top corner in the picture here. And that you can see how happy that little baby looks. And because it's raw and weepy and scabby, poor old Archie there will be pumped full of antibiotics for no good reason. He clearly isn't septic or unwell. Once you rip away the skin barrier, your skin weeps. All of us have burnt ourselves at some point. And you will notice that the blister fluid is golden yellow, and that once open weeps and can be quite sticky. And that's all that's happening with eczema in most cases. Once you scratch the skin, because eczema under the microscope is formed of lots of little blisters, You scratch the skin, you open those blisters, and the skin weeps and crusts and scabs. And Staphylococcus, which is a very, very common bacteria that lives on the skin, is a very common driver of eczema. That does not mean it's infected. It means that eczema is aggravated by the Staphylococcus on the skin, which is why a lot of our patients are given antibacterial washes to use. So eczema, you can see in that bottom picture how blistery it is. Can you see the little spots that are raw? Those are the little blistered areas that have been scratched away. And then we can see typical sites in the arm. And then sometimes adults have what's called nummular or discoid eczema, where eczema is more patchy and round and sometimes gets confused with psoriasis. Psoriasis, you can see, is a duskier, paler shade of pink. And it sometimes can be tricky to tell the difference, but in general, eczema is itchier and redder, and psoriasis is scalier and paler. Both of them are debilitating chronic conditions. It's really important that you moisturize, and I talked about this right back at the beginning, but patients don't really understand why they need to moisturize. I've talked about the barrier function is vital that we moisturize, but it also not only does it help your barrier function heal, and without that barrier function, we are never going to control the skin disease, but it also helps your prescribed treatments work better. Topical steroids, there's often a lot of phobia about topical steroids. It's very rare for GPs to overprescribe steroids. They tend to underprescribe. So if you have been prescribed a steroid by your GP, it is likely that it is safe to use as he has instructed, even on the face. We do have issues where GPs have prescribed steroids and somebody else then says, oh, you shouldn't use that. It's far too strong. My auntie used it and her arm fell off, whatever. The pharmacists say, oh, you shouldn't use it because the child's too young, or you shouldn't use it on the face. But clearly you have seen a doctor and that has been prescribed. Do trust your doctor. If he is unsure, he will tend to ask us for advice. You should continue the treatment. Nothing happens overnight. Most of our patients will say the steroids don't work, but they've been used for 5 days. We need 4 to 6 weeks to really give a good idea of whether something is worth trying. We don't have a huge amount of cream options in eczema and psoriasis. Therefore, before we give up and give you tablet drugs that are potentially dangerous, you need to make sure the simple stuff doesn't work. You need to make sure you keep a stock of your medication. If you don't request your meds for more than 3 months, as you know, your doctor then drops it off your repeat prescription. And when you really need it, you haven't got it. So make sure you've always got one further tube of your steroid in the cupboard so that you can reach for it. And don't get too complacent. So when that eczema is better, don't let all your moisturizers run out. Don't let all your steroid prescriptions run down. And just ignore it, because once you stop moisturizing and the skin starts to get dehydrated and the eczema flares, you'll have nothing to turn to. So just keep up with that good skincare I talked about right back at the beginning. And my top tips for treating dermatitis of any kind, and I'm on a video now, I'll show you later, but I've got a nice patch of eczema when I come back. But don't stop treating too early. Don't just treat the flares. It's just like weight loss. This is a change in lifestyle. This is not, my patients come to me and say, I've never had this before. I'm 50. Why have I suddenly got eczema? And I say, aren't you lucky you haven't had it for 50 years? You do now. So now you have to change your lifestyle. You have to wash less, moisturize more, and treat with creams. If your treatments are not working, if your quality of life is severely impacted, or if you think that the creams are just not good enough, you do need to see a specialist. And sometimes you do need to push quite hard to see a specialist. There are new drugs in eczema and psoriasis, and there are injections and tablets that some GPs are not even aware of, and many patients aren't aware of. So they sit out in the community. I've had psoriasis all my life. I've seen a dermatologist in 1990. There was nothing I could do. I just put up with it. There is new stuff. So if you have bad skin disease, you should be reassessed. There may be something that we can do for you. I'm going to talk about how we get to see a GP in a minute. So obviously, some patients want to see a dermatologist because they don't want to use their creams. And in certain situations, that's valid. It's difficult to get on with normal life, and especially if you have young children, or a full-time job, if you are expected to get up every morning and moisturize top to toe and apply a cream, and then get home and shower with a special gel, and then moisturize, and then put your cream on again, and then do it again at night, that is not conducive to normal lifestyle. Therefore, even if your skin disease is managed, as long as you spend 2 hours a day on it, there may be better options for you. I'm going to talk briefly about lichen sclerosis because it was mentioned in one of our questions, and it's an uncommon chronic condition which affects the perineum and genitals with scarring, itching and splitting. It's far more common in females and it often presents late. So why do I bring this up? I bring it up firstly because someone asked me to, but she's right. It's uncommon, but it's important. It scars and it can cause significant disfigurement and morbidity. Please mute yourself. It can cause significant disfigurement and morbidity if untreated. So it presents with itching or soreness, often in the genitals. It can affect non-genital sites, but actually that's not really that much of a problem. Often just appears like a little rash. But when it affects the vulva, it causes symptoms that might be a little bit like thrush initially, but the treatment either only works very briefly or doesn't work at all, or it keeps coming back. You can get burning, itching and splitting of the vulva, and less commonly of the glans penis. Now, the glans penis, for those of you who aren't anatomically and don't name things anatomically, that is the end of your penis, the bell end, as we call it. So that's under your foreskin. How do we help? Well, I put here, don't drip dry. So what we have noticed over the years is that circumcised men do not get lichen sclerosis. And that's because in us ladies with the flappy bits of skin around there and men who have a foreskin, residue of urine gets trapped under your foreskin and in your labia. And those residues of urine 3, 4, 5 times a day for the last 30, 40, 50, 60 years irritate and set up a chronic inflammation. That's not the entire cause of lichen sclerosis, but it is a driver and a trigger. So make sure that you do dry properly, but you don't wash excessively, because we need that barrier function even on our genitals to be intact. Just like I've told you for the last hour, any excessive washing can irritate. And that is especially the case in the genitals. And we get the problem with people who have any rash on their genitals around their bum, that we think that we're not being clean enough. And therefore we compensate by overwashing. We might wash 2 or 3 times a day. We might use stronger soaps, and that's exactly going to do the opposite. So whenever you have a dermatitis or soreness affecting very gentle skin in your genitals, around your bottom, you actually need to make sure you pull back on the washing. Gosh, we've covered a lot. I'm going to take a breather. So everyone's going to scribble down their questions for later because I know I'm covering way too much. But anyway, we're all having fun, I'm sure. I have plenty of patients. A lot of people are worried about allergies, and you can tell that because the high street's full of these weird allergy clinics where you'll hold a metal stick and they'll wave a chicken at you. All very odd stuff. There are several ways we can be allergic. And in skin, there are 2 main ones, and that's either type 1 immediate or type 4 delayed. Now, type 1 immediate, everyone's heard, is like your peanut allergy. I eat a peanut, 5 minutes later, my lips swell, I can't breathe, I faint, I might die. That is an immediate type 1 allergic reaction. That is never going to be something you didn't know you had. If you have a type 1 allergy, you do need to be referred. You do need an EpiPen. You do need to take care, especially if you're asthmatic, because almost exclusively the only deaths we have from immediate allergic reactions are in asthmatics. Type 4 is a delayed contact eczema. So that means you come into contact with something regularly and over time you become allergic to it and it causes a rash, and that can happen when you're allergic to your shoe leather, which causes a foot dermatitis. You're allergic to your mascara, it causes an eyelid rash. You're allergic to your face cream, it causes face rash. There are, you will have noticed, type 1 and 4, there's 2 and 3 missing, but they are very sort of complicated reactions, more to do with drug and autoimmune allergies. So hair dye is the common one. These two people have both developed significant allergic reactions. This poor lady, I mean, look at this poor lady, and that's just from, she dyed her hair without doing her patch test. So your hairdresser should always advise you to do your patch test, theoretically every single time you have your hair dyed, but certainly a minimum of once a year. You must remember that they change the ingredients in your hair dye willy-nilly without informing you. They don't put a huge label on it that says this has a new ingredient on it. They might change the fragrance, they might change one of the dye chemicals, but you will not be aware of it. And you can also become allergic to anything the longer you use it. So just because you've always used the same thing does not mean you can't become allergic to it. In fact, it's the exact opposite. If you are putting a chemical that is irritant on the skin, the more you use it, the more likely you are to become allergic to it. Just a few points about allergy. If it's food, you either get a rash within minutes of eating, like we talked about, or you can get a flare of eczema in the next few days. And that last one, you can see, is much harder to identify. So we can do prick tests if you're allergic to peanut or prawns or whatever it is, and they just prick the skin with a little needle and apply the allergen, and you can get a little hive reaction, and that's very common and easy to treat. If you eat a food and it makes your eczema worse, it's really, really hard to detect it. It's really hard to test for it. Even if your prick tests are positive, that doesn't mean that it's causing your eczema, because as I've just told you, that's a totally different type of allergy. So just because I stab you with a tiny bit of chicken and you get a rash doesn't mean chicken flares your eczema. So it can be really difficult, and the only way to really sort it out is to do exclusion diets. And when you are excluding a lot of foods, it's really important that you get medical advice about that. I'm going to take questions later because we're nearly at the end. I'm sure you'll all be pleased. Increasingly, we're open to consider cosmetic surgery these days. It's really important that you consider that carefully, that you speak to a specialist who might be a doctor or a surgeon or a specialist nurse, and that to get an idea of what would be appropriate for you. I think more and more there are very excellent options for non-surgical procedures. And most of you watching any kind of TV will have at least once a week, or if not twice a day, thought, oh my God, what has that woman done to her face? Even our rich and famous celebrities seem to come awry with cosmetic surgery. So it's not about cost, it's about expectations. And we must be aware that most of us still want to look human at the end of it. So be very careful that if you are going for surgery, it is surgery that you wanted, not that your cosmetic surgeon told you would make you look wonderful. It's really important that you research the experience of your surgeon to check out what else they do, and to get more than one opinion. And if most of your friends think you're mad to get cosmetic surgery, you probably don't want to get cosmetic surgery. So yeah, just be careful. How do we get medical advice? Okay, so pharmacists can be very useful, first port of access, GPs as well. You do need to follow your doctor's advice when you're given it. And we need to remember that in these times where it is increasingly hard to get an appointment, we have two other ways of seeking medical advice. And one of them is through A&E when we are having had an accident or an emergency. A&Es are full of patients who have not had either an accident or an emergency. And unfortunately, that means that people do wait. So your husband who has a stroke next year, who waits 4 hours for the ambulance, that's not good. So we really must be really, really aware of how precious our A&E services are, and make sure we don't abuse it. We have an out of hours or urgent care service. Our one at Corby is absolutely fabulous. tend to have a shorter wait, and they're really good for minor injuries and when you have not been able to get advice from your GP. But neither of them are there to be used because you can't get an appointment. And if you can't get an appointment to see your GP and are being driven to seek out of hours, then it is vital that you skip through options 1, 2, 3, 4 and ask to make a complaint to the practice manager and say, I need to see a doctor. I can't see a doctor. We cannot continue this situation where patients attend urgent care because they can't get to see the doctor. We have patients coming in late to A&E with significant illness because they haven't been able to see a doctor. And I have told you, I totally understand the GPs are overrun. But unfortunately, the triage service doesn't allow you to decide, to actually get yourself sorted. We also have GU Clinic. So if you have any lesions affecting your genitals, that's a really easy, quick option. Should I use Dr. Google? Absolutely, definitely. Dr. Google's fabulous. I use it all the time. So the internet is a source of total disaster if you don't use it carefully. But if you are concerned that you have a rash, many of my patients turn up having had the diagnosis themselves. But look for legitimate sites. Do not go on blogs. Do not go on patient groups until you have a definite diagnosis and just need support. So there are places you might look for skin cancer advice, such as the NHS website, the British Skin Foundation, Skin Cancer UK. The Primary Care Dermatology Society, which I've put the email there, is a GP website aimed at GP education. It's fantastic because it has so much information about all the conditions. You can even put in, spots on legs, what are the causes, lumps on head, what are the causes? So do use it because you may be able to find that actually I've reassured myself, I know I have a wart, it's fine, it looks exactly like a wart, it's behaving exactly like a wart, I can relax. But if you do want to see a dermatologist, on the NHS, you're going to need to be referred, and that's usually by your GP, occasionally by your specialist if you're under somebody else who has a link with me. So, for instance, some of my patients will be referred from orthopedics because they have a rash that might affect their surgery. They might be referred from rheumatology because they have a rash that might be associated with their arthritis, etc. So when it is hard to be seen, make an appointment to see your GP, you're often able to send a photograph, and that's really valuable. However, you need to go back to Dr. Google and Google, how do I take a good photograph of my skin lesion? Because in the dark, from an angle, facing backwards is not helpful. So we need to be really careful. I've always surprised in this age where everyone is taking selfies, how bad the photographs we get are. And it's really important just to think about it sensibly. It's much better to have someone take your photograph for you so that it can be with the light behind them, straight on, face on, rather than at a weird angle. You're never going to be able to take a picture of something on your back helpfully. You're probably not going to be able to take a picture of anything on your face and have it in focus. So do ask and get the GP to have a look at that photograph. Your GP will then send it to me 9 times out of 10, and you will get a consultant opinion very quickly because we use a service called advice and guidance. And we can say, that looks absolutely fine, or actually, no, I need to see that. If you've decided you'd like to see a dermatologist, but you either can't be referred or don't want to wait, you can see a dermatologist privately, but you should make sure it's the right doctor. And I say that because actually for some lumps and bumps and growths, you're better off seeing a plastic surgeon, and you'll be wasting your money if you come and see me and I need to refer you on to somebody else. So do some investigation. Most doctors will have a website or speak to their secretaries. Don't just book in with the hospital without first identifying that that's the right person for you to see. I get people booked in for allergies, for instance, and of course we need to see an allergy specialist for that. You can refer yourself. You don't need to have a letter if you're not insured, but if you are insured, speak to your insurance company. They'll probably need you to have a letter of referral from your GP. And unfortunately, right now, don't expect it to be very quick because even privately, there are very, very long waits. Right. So in summary, be sensible, look after yourself. If you're worried, ask. And if you ask, follow all instructions and then ask again. And don't forget, we have a great advice and guidance service. If your GP hasn't suggested it, suggest it to him. Say, can you ask the dermatologist? I hear that they do A&G. and they'll send us a little note and we'll give you a response. And I think that is enough because I'm quite dehydrated now. Let me stop sharing.
Thank you, Olivia. That's
Cool.
absolutely fantastic. I hope you've got a glass of water to hand. Brilliant. Oh, look at that. Excellent. Right, we've got some questions, some of which you have answered, but some of them, these are new ones that have come in. So I've got a question here from a guest, Bowen's disease. Bowen's disease on heel, and another person, Bowen's disease and marks on their face.
Okay, let me look back at the email because I think there's you emailed me those ones.
I did, and then also I've had some more that have come in.
Okay, right. So so somebody wanted to know about how to get back to the GP, back to see a dermatologist. I think I've covered that. Chronic dermatitis affecting heel, how to manage it. Okay, well, to be fair, there's two ways you're going to manage your chronic dermatitis. The one is, or actually we'll go for three. The one is you do need to be using really strong urea-based moisturizers. So Flexitol or Heel Balm are the ones that commonly you can buy over the counter. And you need to be doing that 2-3 times a day. And if despite that, you are still splitting painfully, then you're going to need to be referred in for other treatment. If you are managing it, then you're going to have to put up with it. This is you. Some people, as they get older, get very dry, thick heels, and you just have to put up with it. If it's not painfully splitting, you're probably not going to want the drugs I have to offer you. And unless it's itchy, steroid creams aren't probably going to be very helpful. Pigmentation on the face, I mentioned it's all to do with daylight. So there are racial changes. Some people find that they pigment much more easily. Some of them are very hormonally linked, but all of them are triggered at least in part by sunlight and daylight. So sunblock. Did you send me some other questions since then?
Basal carcinomas, should they always be treated? You talked about that, didn't you? Mm-hmm. I've got some more that have just come in.
Okay, yeah.
So I don't know if you addressed, the Bowen's disease, you've already addressed that.
So what was the Bowen's, what was the question?
I've got a Bowen's disease on my heel. Can it affect other parts of my body?
Okay, so Bowen's disease is a type of sun damage which causes changes that look a little bit like a patch of eczema or psoriasis, pink scaly patches. They're very common on the legs, and they can be very difficult to differentiate in primary care. So if you've had a dermatologist make that diagnosis, then great. They can often be treated with creams. They don't need anything radical, but they are precancerous. So if ignored completely, they can occasionally cause a skin cancer, but they cause that there on the skin where you are. So if you've got Bowen's on the hand there, that tattoo is my patch of Bowen's, it could turn cancerous. It's not a definite, but there is a risk of that turning cancerous, which is why we try to treat them to reduce that risk. The cancer it turns into is squamous cancer. And there's absolutely no way you will remember, but about 30 minutes ago, I told you that SCCs grow really rapidly and you won't ignore them. And that's why we don't get too worried about Bowen's, because if it turns cancerous, you're going to know about it. You're going to do something about it. You won't ignore it. You'll get it and we'll sort it out. Yes, we would like to remove it, especially at high risk sites. So there we are. Let me get to that question. Had it removed on my heel, new patches on my face, which look the same as the Bowen's on my face. Yes, so on the face, we tend to see more actinic keratoses, and they can mostly be treated with cream. So as I say, the Bowen's on your foot was removed probably because it's a bit of an unusual place to have it. And so someone wanted to make sure that's what it was, or it failed creams. But actually, that patch doesn't spread. That patch was caused by sun you had over the last 50, 60, 70 years. And so the rest of you also had sun. So skin cancer doesn't spread around you unless you have nasty melanoma, unless you have a proper cancer. But what it does is you're much more likely to get others, because if you had enough sun to cause one skin cancer or one area of sun damage, chances are the whole of your back, your face, especially your head, if you are a bald chap, will have had that exposure and will be sun damaged. So yes, you should speak to your GP and maybe get some creams.
Great, thank you. Another one. Is it okay to repeatedly use hydrocortisone cream
Yeah.
with an epiderm cream?
Okay, so if you were using hydrocortisone every day on your eyelids, I might be concerned that gradually you might thin the skin or damage the skin. If you were using hydrocortisone regularly, day in, day out on your baby, I might be concerned that you were going to cause damage. If you were using it in any other situation, you're probably safe to continue forever. Hydrocortisone is very weak. If you're using a tube a month or just using it on any bit here or here, wherever, on your arm, on your bum, on your knee, and it does the trick, then that is absolutely fine.
Great. Another one. Now, forgive my description of this. Since COVID, this is a health NHS colleague. Since COVID, we're seeing more bullous pemphigoids.
Pemphigoid, yes.
Oh,
absolutely.
Right. Do you think that more than this individual saw 30 years ago or in the last 30 years? Do you think
Okay,
there's
let me
a
just
link? You don't
read
have
it
that
through.
question. I've got it.
That's fine. I have an appointment with dermatology. Okay, so just quickly back to Vicky. You probably don't need an appointment in dermatology. This is the frustrating thing. Your GP just needs to treat you. You'll wait till October to have a cream that I can give you, that your GP can give you. So do nag your GP and say, can I not just have some cream? Because it's pointless you waiting 6 months to have a cream that your GP can prescribe. Anyway, bullous pemphigoid. Do we see? I do think we've seen more bullous pemphigoid. I think there are maybe a few reasons that that's happened. I think one may be that those frail old biddies would previously maybe not still be here if they hadn't been hiding indoors for 3 years, not catching flu and dropping down, because and we're also increasingly getting a more elderly population. I also think it's a timely thing. You might be feeling it right now. I always find that I get a flare of pemphigoids between about February and May. I don't know why. We always see a bit more pemphigoid. Yeah.
What's a pemphigoid, Lydia?
Pemphigoid is a blistering disease of the elderly. So a patient that turns out with a rash that looks a little bit like eczema, and then it starts to get big bubbly blisters. And it's very debilitating and uncomfortable and needs to be treated nice and early, but it does burn out in a couple of years. But it is very much a condition of the elderly.
Great, thank you. Do nodular melanomas, where's the question gone? Grow externally?
Internally, externally, yes. So a nodular melanoma, yes, will grow like a boil. So they're often red ones rather than black ones, unfortunately, but they are not subtle. So they'll start as something, and then I don't know. Can you see my video? Is everyone on? Am I on video?
Yes, hopefully people
so
can.
they'll just do, they will erupt. So yes, you'll see it.
Okay.
Nodular melanoma tends to appear really quite quickly, 6-8 weeks, whereas most melanomas take 6-8 months, 2-3 years to develop.
Yes. Okay. Still some more BCC questions, but again, they, should I get them removed?
If they're on your face, definitely.
If you're on your leg,
you should definitely treat them with chemotherapy creams. There is a low-risk basal cell carcinoma service at Woodsend. Please ask to be referred there because they'll see you within 2 or 3 weeks. Magic, Dr. Khalid there is fabulous. And he runs what we call our low-risk skin cancer service. So these are patients who have skin cancers neck downwards of basal cell cancers. And if it's the wrong place, you've only wasted 2 or 3 weeks because he'll send you on to me.
Great. And that's Dr. whom?
Dr. Khalid. He was the man. He ran the practice at Woodsend. He's now only just doing skin cancers. He's semi-retired. I think Dr. Kumar is doing it instead. But anyway, yeah, he's our low-risk BCC surgeon. I have a lesion on my arm. I can't get to see a GP. I have a photo. You need to phone the surgery and you need to say, I'd like to send my photo. Go in for a review, please. And if you can't get through on the admin on the telephone line every morning at 8 o'clock, you get thrown out at 8:30. Phone and ask to speak to one of the secretaries. Choose option 3 or 4 or whatever it is that says, can I speak to the secretary?
Brilliant. I think we need to draw it there. It's 5:15. You have been absolutely amazing. Our guests have been amazing for having the patience. But thank you so much, Olivia. I think that was so informative.
That's fine. I'm glad. I hope everyone enjoyed it. And I'm sorry you all missed if you didn't come to Skin Cancer last week. We had 640 patients in. We'll hopefully run the event again next year.